Welcome to the show, Your Healthcare. I'm Dr. Lahav, and in this show we discuss medical-related topics and issues. How much do you know about anesthesia? The types of anesthesia you can have for different types of surgeries, procedures, candidate for different types of anesthesia. And what about one of the hottest topics really today in the United States, pain management? What do we do about it? What are the options available? How do you monitor these narcotics and pain medications that are out there? Today we have with us Dr. David Glassman, specialized in anesthesia and pain management, who will teach us about some of these anesthesia topics as well as controlling pain. In addition, at the very end, we have a very special surprise. Never had it in this show before, so stay tuned. I'm Dr. Lahav here with Dr. David Glassman. This is Your Healthcare. We'll be right back. Welcome back to Your Healthcare. We have a very special show today, something we haven't had on through the entire career of Your Healthcare. I'm Dr. Lahav, and today we're going to discuss anesthesia and pain management. First, let's start a little bit about anesthesia. If we can go to the presentation, please. So if we discuss anesthesia, anesthesia is a way to control pain during a surgery or any type of procedure by using medicine called anesthetics. And there are different types of anesthetics that can be used. It helps control your breathing, your blood pressure, your blood flow, your heart rate and rhythm, and of course, control any discomfort during the procedure. Anesthesia may be used to relax you, block pain, make you sleepy or forgetful, sort of a twilight sleep, or make you especially unconscious, such as general anesthesia, for your surgery, depending on the type of procedure that you may have. Well, what are some of the types of anesthesia used? There's local, regional, epidural or spinal, and general. Local anesthesia essentially numbs a small part of your body for minor procedures, and you may actually be awake for these type of procedures. Regional anesthesia blocks a regional portion, which means it blocks pain to a larger part of your body. It may also get medicine to help you relax or sleep, to be comfortable. Types of regional anesthesia include peripheral nerve blocks, and it's a shot of anesthetic to block pain, especially to a limb, such as an arm or a leg. Then we move on to epidural or spinal anesthesia. That's a shot of anesthetic near the spinal cord and the nerve roots in your back, and it blocks pain from an entire region of the body, such as the belly, hips, or legs, which is used a lot for lower extremity type of procedures or upper extremity type procedures. For lower extremities. For upper, usually use more of a regional type of anesthetic. General anesthesia is the final type of anesthetic that can be used, affects your brain and the rest of your body. Essentially, you're out for the procedure. You may get some anesthetic through a vein, and you may breathe in some of the anesthetics as well. With general anesthesia, you're essentially unconscious. You don't feel pain during the surgery, but you also don't remember anything at all either. So some of the local anesthesia can be used even to the dentist, for instance. A little shot of Novocaine, for instance, or a little procedures for the hand can be used just with some local anesthesia. Regional anesthesia, here we're showing essentially a brachial plexus block for procedures such as rotator cuff surgery or upper extremity procedures. It blocks essentially any pain from your arm essentially feels dead, but it helps control discomfort for that type of procedure. Epidural or spinal anesthesia. Epidural just means you have to put a catheter in. Spinal is a one-time shot. It's also actually the positioning of the needle for this type of procedure, which differentiates between spinal and epidural. If you deliver, if you're going to be a soon-to-be mother, for instance, this is type of the anesthesia that can be used to deliver your baby, the epidural anesthesia. If you have lower extremity, essentially joint replacements, we use things like spinal anesthesia, again, numbing you from the waist down. And finally, general anesthesia. You lie there, you breathe in some anesthetics, or you get something through the vein, and then you're out for the procedure. When you wake up, everything is all done. Well, what determines the type of anesthesia that is used? Well, your health is actually very important. Your past and your current health, which includes other surgeries you may have had, any health issues such as heart disease or diabetes, any other comorbidities, will dictate the type of anesthesia that you would be best suited for. The type of surgery also matters. For example, you may need general anesthesia to ensure your comfort and safety during certain type of surgeries, such as abdominal surgeries, for instance. And the results of different tests that you may have, such as EKG or other blood tests, to determine what is the best type of anesthesia that will be the safest for you. So welcome back, and I wanted to jump right into it and introduce our guest today, Dr. David Glassman from Anesthesia and Pain Management. Dr. Glassman, thank you very much for being here with us.
Well, thank you very much. Thanks.
I think this is actually a topic we haven't discussed before. You know, we discussed different procedures and illnesses and ailments, but really we haven't discussed what is the most comfortable way of doing things with anesthesia. How do we do these procedures? What is the patient going to expect? What type of anesthetics have been, let's say, historically, and what are some of the new advancements with anesthesia to make the patients more comfortable and more in the outpatient settings is the trend now rather than hospital settings for a lot of different type of procedures. So let's talk a little bit first about a little bit of your background with anesthesia.
Well, again, I was, we've worked together. Been in the OR plenty of times together. Again, I come from background of obviously did a residency in anesthesia over at Yale, and then came back actually after working as an anesthesiologist in New Jersey, came back, did a fellowship in pain medicine back at Yale, and then had a pain practice for 10 years, and now coming to Milford as an anesthesiologist practicing.
So you actually had, a subspecialty in anesthesia, which was pain management, which we'll discuss in the next segment. So we're going to concentrate more on the kind of the anesthesia portion of it. Yeah. And, a lot of individuals come in and they ask, well, what type of anesthesia do you use? For, let's say, for myself, for my procedures, joint replacements, which is lower extremities, essentially. How do you determine, let's say, regional versus spinal versus general?
Yeah, again, it was a very comprehensive, very good, description of all different types of anesthetics before. I think that, again, the choice of anesthesia, again, is determined by the type of, surgery, and also as well as, patient medical history, so I think that largely it's a discussion between surgeon, patient, and anesthesiologist to determine what the best course of anesthesia is. For example, as you mentioned before, joint replacement is very well suited for regional anesthesia. It's a very good use of typically spinal anesthetics that we administer medication in the back to essentially render an anesthesia part of the body that we can sort of isolate, and with local anesthetics that are injected in the back.
So actually, you mentioned, you do like a spinal anesthetic in the back. Most people say, well, I don't want a needle stuck in my back. It's stuck in my spinal cord. And that's actually a misunderstanding. The needle doesn't go into your spinal cord. It actually goes around it. And maybe you can differentiate between, let's say, a spinal, a one-shot injection in the lower back, which numbs you from the waist down, versus something like an epidural, like in obstetrics, where a mother-to-be is going to deliver. She gets an epidural. She doesn't get particularly a spinal, because an epidural is quickly reversible as well. Right. So how do you actually do that? Where does the needle go in your back when you're sort of leaning forward and you give this injection in your spine, so to speak?
Right. Well, and there are very fine distinctions between epidural and spinal. Both are needles in the back. First of all, we use plenty of, Novocaine or lidocaine in the back. Essentially, we make it very comfortable as far as a placement of the needles. It's not really felt. Maybe some pressure. The difference between epidural spinal actually goes inside the spinal sac, which encases the spinal cord and nerves. And by the way, when we do a spinal anesthetic, the spinal cord actually comes about midway down the back, and so we're not even near the spinal cord. So that is actually a misconception, that there really is no risk of paralysis. We're not near the spinal cord when we do a spinal anesthetic. There are nerves that go down there, which are freely floating, and they float away from the needle as it enters into that canal. The epidural needle actually, when we talk about an epidural, actually doesn't go quite that far, but it goes just before that little membrane. Right outside of it, actually. And
right outside the sac,
right
which contains the nerves.
Right outside the sac. So we actually don't puncture that sac with an epidural.
All right, that's where you can slide the catheter in there. So if you really look at a model of, let's say, your spine here, looking kind of from the back here, this is sort of a side here. So in the back, the needle essentially goes right into here, between the elements in your back here, where your cord is, or the nerve roots are in the middle here, as you can see, right there. The cord will be right in here. Essentially, the needle goes into here at different levels. It can be done. And then the anesthetic is injected into this area. And for the epidural, it's injected outside the sac where the nerve roots are. And for spinal, it goes inside the sac where the nerve roots are inside here, and kind of numbs the nerve roots in that region. So that's really the epidural versus the spinal. It's not injected into your bone, or it's not injected into your spinal cord. Correct. And then, depending on the health of the patient, when some people say, well, I want to be knocked out, I don't want to know anything about it, I want general anesthesia. And there's a difference between general anesthesia and regional, or with, let's say, a twilight sleep. General, essentially, you go on a ventilator. I mean, you're on some machine that helps you essentially breathe.
Correct. So a general anesthetic, again, it involves multiple drugs that kind of combine to form what's called general anesthesia, that essentially is an unconscious state. Typically we'll use an intravenous route catheter to have the patient go off to sleep very comfortably, very relaxed. It's all a very relaxed environment. We want everybody to feel very nice. Typically, I'll say pick a good dream, before they go off to sleep. And that's it. That's really the last thing you remember. I mean, I've had anesthesia when I was 16, and so I don't remember any part of my surgery. I've had subsequent procedures with propofol. Typically, it's one of the drugs that's very commonly used to have the patient go off to sleep.
Yeah, propofol is actually it's a very quick-acting medication that actually it almost looks like you're putting milk into the vein. It's a very white type of compound. But it knocks you out pretty much like this, and it doesn't last
Very quick.
that long either.
Very, very quick and very quick offset, very quick onset offset. It's a very smooth drug. It's really replaced, really the drug that was commonly used prior to that was thiopental, and so that maybe you can go down to the Smithsonian to find that, but that's pretty much propofol is the mainstay drug.
And it's nice because again, it's easily reversible. I mean, the onset is quick and it goes away very quickly. And if you want to keep the patient comfortable, you have to kind of do a constant drip.
Constant drip, so total intravenous anesthesia, as we call it, TIVA, where we may actually combine that with a spinal anesthetic. So they'll just be sleeping. There's a kind of a constant drip of propofol going in, continuous. Keeps you in a very nice, relaxed, comfortable sleeping state in which you're just unaware until we turn it off, and then you wake up.
So for procedures such as, let's say, colonoscopy or endoscopy, where you obviously don't want to be awake when there's a hose shoved up, from the bottom, or a hose going in from the top, but you're still breathing on your own. You just kind of sort of very comfortable state, and don't remember anything, you don't feel anything.
Correct. Yeah. So again, propofol is a sedative, hypnotic, and amnestic. So you will really kind of works, kind of just shuts things off for a little while. While it's taking effect. It's short acting, so to maintain kind of a continuous state, you have to kind of redose or do a continuous infusion. But with the drug itself, it's a very, very smooth, very quick acting drug.
And what about I have patients say, Doc, I'll go with whatever anesthesia you suggest for the procedures, but I don't want to remember anything. I don't want to recall anything. I just want to get it done. When I'm done, I'm done. I didn't remember anything from the procedure. So, if let's say the patient doesn't have to have propofol, which is one of the options you can use, you use other type of medication to kind of cause this forgetfulness?
Yeah, I mean, there's a whole armament of anesthetics and medications. Benzodiazepines are a very useful drug. Benzodiazepines are more commonly known Valium, or what we use in the operating rooms, Versed, and Versed's a little bit more of a shorter acting version of Valium. Valium being a much longer acting drug. But when we combine different drugs, we have a kind of a combination Versed fentanyl technique is what we call it. So fentanyl is pain analgesic pain drug, a morphine type drug, and so those combinations you don't really remember too much after they're given.
And then some people, describe, I don't want to, I'm afraid of getting something through my intravenous, through an IV. Can I breathe in something instead? How do you kind of work the anesthetic between something that's inhaled and something that's given through an IV, for instance?
Yeah, well, those, again, the IV and the inhalational, those are all part of, combined to form, quote unquote anesthesia. We talk about inducing anesthesia, so you can use the intravenous route, or you could use an inhalational route. And we have certain situations, sometimes in pediatric cases, where it's a little bit more of a traumatic thing as a small child to have a needle and an IV. So we'll just have them come in and bring them into the operating room with inhalational inducing, and so they'll just breathe in some of the agent, makes you go off to sleep, and it's a very, very nice way to induce anesthesia.
And one important topic, especially with general anesthesia or sometimes even a regional anesthesia, is nausea and vomiting. And historically, there's been different medications that anesthesia has used that can cause a lot of nausea. Now, more recently, obviously, you guys have been really on top of it and working very well, and you've done, hundreds and hundreds of patients of mine as well. For the fact that you use some other type of modalities to help decrease type of, nausea and vomiting that, is commonly referred to in the past. Whenever you have anesthesia, you're going to be vomiting afterwards.
Yeah, and again, with sort of the advent of anesthesia as it's developed, nausea was more of an issue with previous anesthetics. Still an issue, but again, nobody likes waking up with those type of side effects, and in some cases it's so severe that it requires an admission. But we have very good medications, and actually in certain techniques that we use, and propofol actually is an anti-nausea medication. Used in small doses. Sometimes we use it for patients who are getting chemotherapy who develop severe nausea, and propofol is pretty potent anti-nausea. So sometimes we'll use just propofol techniques for people who have a history of motion sickness or nausea, or nausea with previous anesthetics and surgery. And we have multiple different drug techniques to take care of it, either in the operating room or both the operating room and then afterwards in the recovery room.
And let's touch a little bit on some, let's say, the risks associated with. I'll go back to sort of regional, because spinal and epidural is used obviously a lot, especially for lower extremity surgeries and in obstetric cases, in some gynecological cases as well. Spinal headaches. What does that mean? What it is? How do you treat it? And really, what is the recurrence that it can happen?
So spinal headache is, the headache portion doesn't sound so bad, but a spinal headache is a very bad headache, and it is actually is something that can occur from spinal anesthesia. It sometimes requires treatment, so basically the occurrence of spinal headaches are less than 1% nowadays because of the type of needles that are being used. So it is a low incidence, but we will treat it if needed.
So a spinal headache is really when you have a leak from your spinal sac.
Correct. Yeah. There actually is a tiny little hole that occurs, from a needle puncture that doesn't close, and so in a spinal headache, there is leaking of spinal fluid. Very slow. It's a very slow leak, but
and it's very uncommon. But it does occur.
Very uncommon, can occur, and is very treatable.
All right, so that's also good to know. A lot of time with bed rest, lying flat, and giving it a chance to kind of heal, and then you're up and around, do what you want to do.
Lots of fluids and caffeine.
And just the last minute or two that we have here, a lot of the trend has been kind of to ambulatory setting type of surgery. A lot of these procedures are done really at an outpatient basis. So a lot of these sort of blocks come into effect. Can you tell us a little bit on that, really, the hospital setting versus the ambulatory setting for procedures now?
In regards to the regional blocks?
For the regional blocks and sort of maybe the difference of how things are done. Or maybe there isn't much of a difference regarding the anesthesia component.
Yeah, I mean, I think that, regional blocks have really come into play. Especially in the ambulatory setting and in the hospital setting. They're just, again, when we talk about regional or nerve blocks, so for example, for knee replacement, which will require a hospital admission, we'll block the nerves in the recovery room to the knee. And it does help a lot with pain management and pain relief. which becomes very important. Nobody likes being in pain, and so I think that what it does, particularly with knee replacement, we talk about less hospital stay admission. We talk about faster recovery times, improvement in joint range of motion and recovery, and obviously very high patient satisfaction with that.
So it's kind of taking the in-house type of procedures, shifting to the ambulatory setting, and making the patient more comfortable with different type of anesthetics that can be used, blocks, injections, so forth, to kind of get him going faster and obviously not require the hospital setting.
Yeah, absolutely. And I know as a patient, I would love that.
And actually, we're going to use that segue to head into pain management after this short break. I'm Dr. Amit Lahav here with Dr. David Glassman speaking about anesthesia and pain management. Stay tuned. We'll be right back. Welcome back to Your Healthcare. I'm Dr. Amit Lahav here with Dr. David Glassman. Just spoke about anesthesia, the type of anesthesia that can be used for different type of procedures. And now we're going to segue into pain management, one of the biggest topics that are out there right now. So if you discuss pain management is important for ongoing pain control, especially if you suffer with long-term or chronic pain. Pain management is a branch of medicine employing an interdisciplinary approach for easing the suffering and improving the quality of life for those living with pain. And pain is mostly subjective, although it has some objective components to it. The types of chronic pain medication that is used are anti-inflammatory type medications, like over-the-counter ibuprofen, naproxen, Aleve, and so forth, and some prescription-based ones. Tylenol or acetaminophen, antidepressants, and there are different types of medications that are used at different doses to help with sort of nerve type pain, which at higher doses are used as antidepressants. Anti-seizure medications, which can be effective in treating pain related to nerve damage or injury as well. Steroids, such as prednisone, and sometimes even injectable ones to help treat pain. And of course, also narcotic types of medications. Physical therapy is also a very important part of pain management. Pain can be worsened by exercise that isn't done correctly or is inappropriate, which is what I see in my office quite a lot. If you really don't have the right diagnosis and undergo physical therapy, some of those exercises actually can be more hurtful than helpful. And proper exercises slowly also builds your tolerance and helps to reduce your pain as well. Well, what are some other pain management options? Well, a variety of approaches and modalities are also available. They include what we call TENS, or transcutaneous electrical nerve stimulations, and there's different variations of these. Meditation, relaxation techniques, visual imagery, especially for those who are very stressed, that can actually elevate your pain for many reasons. Biofeedback, heat and cold therapy, manipulation, as well as massage. And what other types of options are available? Narcotics, one of the biggest ones out there. Injections and nerve blocks. And we'll discuss with Dr. Glassman as well about some of these options as well regarding especially injections and nerve blocks, which are done by pain management specialists. Pain can either be managed using pharmacological or interventional procedures, which means you can take different types of medications as well as have different types of injections. And there are many interventional procedures available for pain, which is actually very important because that gives you an option of what you can actually take for pain. So let me actually give you a little statistics here. This is from the Centers of Disease Control and Prevention, which I'll tell you a few numbers. Acetaminophen deaths per year, 450. Acetaminophen or Tylenol hospitalizations per year, 25,000. Acetaminophen injuries per year, 56,000. Hydrocodone deaths per year, just under 14,000. Hydrocodone prescriptions per year, 131 million. I'll repeat that. Prescriptions per year, 131 million. And that's only one type of narcotic. Opioid overdose deaths per year, 16,500. Opioid overdose ER or emergency room visits per year, 120,000. And NSAIDs or anti-inflammatory deaths per year, 16,500. And these are numbers, again, from the Centers of Disease Control and Prevention. So these are real statistics that are out there. And most individuals will come and say, well, I have pain, can I have something for pain? You know, you kind of go up a level of anti-inflammatory medication, Tylenol or acetaminophen. Then you start going into some of the non-narcotics and narcotic types of medications. And it could be a very slippery slope. And that's really where we have some of the specialization expertise of individuals like Dr. Glassman with a specialty in pain management. How do you control this, and how do you work with the patient regarding what is safe for you? I mean, regarding overdosing or using the improper medication, frequency, dosing, that all comes into account really to try to help you manage your pain. So, Dr. Glassman, we're going to jump right into this pain management. Very big topic, and even really now in the United States, every physician is actually required to go on a website before you give a prescription for a narcotic, which is more than 3 days, to actually look at the history of an individual where they filled their narcotics. And that's not just mandated to us as physicians. Patients can't just get a pain medication, let's say in Connecticut, and say, well, I'm going to go to Vermont and get something else there, and I'm going to then go down to New Jersey and get something else there. That doesn't happen anymore. Now you get tracked. So if you fill it, it's in your history, it's in a website. It's available for every pharmacist and every surgeon and internist and every physician that's out there that can see if you got a prescription. So you can't fool the system anymore. It's mandated for the physician to check it, but it also helps protect the patient as well from things like overdosing or overusing some of these medications. So knowing that pain management is a very big topic here, let's just go back a little bit to the fact for a pain management specialist, you know, it's not just giving narcotics. What else is involved in treating pain?
Yeah, so, you know, treating pain, obviously, is a very, very complicated, and involves a lot of. It involves a really kind of detailed plan, very individualized. It has to be multidisciplinary. Many specialists need to be involved with management of pain. It's not just about writing a prescription. Nor is it just about sending somebody for physical therapy. It kind of has to be individualized and picked according to this patient who, the problem with pain is we can't see it. There's not really something that we can measure other than, ask somebody a basic, what's your pain score out of 10? My pain score is a 10. Okay, well, we start from there. But, I think that, every time, a pain physician will see a pain patient, there has to be communication among all physicians involved with that patient's care I think that probably a good plan for many types of chronic pain involve pharmacotherapy or medications, but also involve rehabilitation. They may involve some interventional pain injections that help both with diagnosis and treatment. It may involve psychotherapy, which doesn't mean that anybody's crazy. It's just a big part of a component of pain of the overall person's pain. It's a cognitive part. It's a very pain can break down when you have somebody a pain score. Really, typically I'll say, well, what exactly is your pain coming from? And from that, I get a very detailed description of, well, my daughter is driving me crazy. My husband left me. They start talking about everything else except for their pain. So that really becomes part of the whole.
So it could be also a
process.
social aspect which can aggravate really your pain threshold, so to speak.
Absolutely. Psychosocial is a big component of pain.
And, the scale of, say 0 to 10 of your pain, it's very subjective. If I take a hammer and put your hand on the table and smash it with a hammer, to you it may be, wow, that really hurts, it's an 8. For someone else it may be a 12, from a scale of 0 to 10. If I cut off your leg, I'd say that's a 10, but everybody's is sort of different on how they feel regarding pain. And what's important is also to find out maybe a more clear etiology, like where is it coming from? Because just taking pain medication or narcotics doesn't treat the underlying problem. It helps control some of the pain, but if we're able to find out why you're having it, we can maybe take care of that and get you off some of these narcotics. Now,
Correct.
A lot of things that you see also is back pain. Back pain is one of the biggest things that drives individuals to their doctor and to an orthopedist as well. So injections, for instance, that are done for the back. Let's say you eliminate things like disc herniation or any really significant pathology in your back, but you have pain. You may have a little bit narrowing in the back or dry discs and so forth. And there are different type of injections that are done for back pain, for instance. What are they?
Yeah, so when we talk about back injections, typically everybody thinks, oh, an epidural. I think epidural steroid injections are a very common injection, but really there's a lot that really kind of targets one source of pain in the back. There's probably anywhere from 20 to plus etiologies of pain that's coming from the back. Again, we can, people have, we have to kind of narrow in exactly, well, the nature of the back pain. Is it just kind of localized? Is it radiating? Is it referred pain? Does it go all the way down the leg? Does it just go into, kind of the back of the leg? Does it go to the hip? And so we can kind of, get a little bit more information from that, and as well as doing different types of injections. One type of injection to target a very, actually, a pretty common source of pain is facet-related pain. So each of the vertebral segments in the spine, each has a pair of joints that interlock each of the segments, and those are called the facet joints. And so that causes a certain amount of mobility in the spine, the joints. Each joint is like a little mini joint, like the knee has synovial fluid, has fluid in the joint. If I may.
Yeah, absolutely.
And so similarly, they have pairs of joints in the spine. And so as you can see here, if we turn it to the side, this little synapse here is a joint, and you have the same setup on the other side. And so each level has this pair of joints, which are called facet, and these joints can get inflamed and cause a lot of pain.
And that's the back.
And that's the back.
From the
So
back.
we're looking from the back of the person spinous process, and then the disc being looking here in the front. And so from here we can actually inject nerves that supply these joints and get information. So we can isolate actually a segment or 2 segments or 3 segments, inject the nerves that specifically go to those segments. We use live X-ray or fluoroscopy to pinpoint those spots, and we get information, diagnostic information that's pretty valuable.
So it's, doing these type of injections, obviously, in the location makes a difference, also for diagnostic purposes and potentially therapeutic purposes as well. So that's where the specialization of a pain management individual comes into play, because it's not just giving an injection in the back. It's localizing where it is, and also for different other areas, including your legs and arms and so forth. Things like even reflex sympathetic dystrophy or RSD or causalgia or regional pain syndrome. There's different type of injection that can be done in the area to numb some of these type of nerves that potentially mediate pain. And I also want to touch a little bit of kind of these narcotics again, because that's the biggest thing, but the short-acting narcotics and the long-acting narcotics that are used out there. How do you kind of work that into, let's say, a patient's pain regimen?
Yeah, so again, there's been obviously a large amount development of different types of medications and narcotics. Quote unquote narcotics, which are the opioid medications. Those are the morphine type medications. Have developed, more for really for the purpose of for chronic pain. Developed a long-acting formulation, which is just a synthesized to release the same short-acting medication, but over a longer period of time. And so a typical technique, just to achieve a better pain relief for longer periods over the day, is to combine long-acting opioid or narcotic with a short-acting, and so by using this combination, I think really which applies more for people who have more long-term pain, versus people who have acute pain or who have just developed a pain problem, maybe like post-surgical pain, which the long-term narcotics really are not intended for.
So it is differentiating between sort of short-term and long-term solutions for pain. Things around post-surgical are really not a long-term solution for the type of medications you choose. You kind of want to get the individual through the discomfort of the procedure and then get them back to their baseline, as opposed to patients who, well, let's say we can't determine a particular reason they have pain, because a lot of it is subjective, and sometimes we don't really know the etiology, like why would you have pain where the other person doesn't for the same type of, let's say, injury that occurred. But we take that into account if we have to treat with something. Some of these longer acting medications give you sort of a more steady baseline of relief, rather than the short acting, which kind of spike up and go back down, spike up and go back down. So that's how the pain management specialist can also adjust some of that. And there's different dosages. But one thing that you got to remember, a lot of these narcotics, which people may forget, is constipation. So they do slow down your bowel. And I don't know if historically you've spoken to your patients before to say, we're going to start this, but we do have to worry about some bowel regimen for you.
Yeah, it's an issue. Again, as far as the side effect of constipation, a lot of the side effects with narcotics, they tend to go away after the first few days or after the first week. Constipations, that's one thing that just does not go away. It just doesn't. And so again, either dietary instructions or just to add some laxatives when you're on opioid therapy.
Yeah, because if you have pain management, you're definitely uncomfortable if you can't go number 2. So you got to keep all that really in perspective to make it obviously more manageable to you. So essentially, there are different type of medications that are used, as well as injections and blocks, which are really decided by the pain management specialist. And really, in today's world in the United States, there is actually kind of a stricter rule of who gets these pain medication, how much you can have, and you are being tracked. So there is a certain amount that can be given really safely and legally to you. What we're going to do is we're going to take a short break, and we got a surprise coming up because we're going to make you sit back and relax, and you'll see what's coming up next. I'm Dr. Amit Lahav here with Dr. David Glassman, and we're going to show you a different side of medicine. Stay tuned. Welcome back to Your Healthcare. I'm Dr. Amit Lahav, and today we spoke about anesthesia and pain management. Some safety and information that's available to you regarding of different type of anesthesia that's used for different type of procedures, how we decide what anesthesia you can have. We had the guest today, Dr. David Glassman, in anesthesia and specialize in pain management as well. In pain management, one of the hottest topics now in the United States regarding pain medication use, tracking of it, and safety. But just available to you, you know that besides just pain medication, there are other procedures that can be done and other availability treatment options for you that can help treat your pain. It's really sort of a collaborative effort and an interdisciplinary approach really to try to alleviate the pain that you may have. I'm Dr. Amit Lahav, and I did promise you that we're going to have something special today, which we have not had in the show before, and I'm going to show you another side of medicine. Maybe a better side of medicine. It's not that just we take care of patients and we do procedures and surgeries. We are human beings and we do enjoy other things in life as well. I'm going to introduce Dr. David Glassman as he's going to serenade us with some saxophone.
1, 2, 1, 2, 3.